model about treatment of hepatitis C using the new medications. It's expected in the United States that in 2030, hepatitis C will be eliminated. So in summary, we have wonderful therapies, oral therapies, excellent side effect profile, but watch the drug-drug interactions. I thank you very much for listening.
Thank you, Professor Fouad. Our next speaker is Dr. Tariq Al-Fahd, and Tariq is an assistant professor of medicine and neurology in the Faculty of Medicine. He's a graduate of Kuwait University and went on to George Washington University, where he did an internship and then residency and fellowship in neurology, and followed by 3 years of clinical research fellowship at the NIH. He's going to be talking to us about multiple sclerosis, an update in diagnosis and management, and his research interest is in multiple sclerosis. So we look forward to hearing what he has to say. Thank you.
Thank you, Professor Zubayd, for the kind introduction. Assalamu alaikum. I'd like to thank the organizing committee and Dr. Mohammed Al-Aoum for the invitation to be here with you this afternoon. I'll be talking about multiple sclerosis, mostly about the diagnosis and management of it. This is my disclosure slide. So we'll start with a brief introduction, followed by diagnosis, treatment, and concluding remarks. As all of you know, MS is an inflammatory, demyelinating, and neurodegenerative disorder of the central nervous system. A peak incidence usually between the ages of 10 to 40 years of age, mostly in women. And we already know from years ago that 10 to 15% of the cases occur in first-degree relatives of patients with MS. The new thing that came a few years ago was from a big GWAS study, where they found there were 108 allelic variants in multiple sclerosis. 90% of them are in the non-coding region. So the old idea that there is one gene that could cause the disease and we should go after it is no more valuable in MS. One of the interesting things was that 50% of those alleles were shared with other autoimmune disorders. So the belief is that we're going from looking for a single gene that causes a disease to pathways that are affected by all these alleles at different times during the patient's lifespan. So as all of you know, the natural history of MS starts with what's known as clinically isolated syndrome. That is basically the first time patient come to our attention with a clinical relapse, where they will develop new symptoms lasting for days, weeks, and sometimes months, and then most of the time go back to baseline or improve with some residual deficit. They go on to have more relapses, a phase that's called relapsing remitting MS. Around 85% of the patient would follow this route. And then something changes, where the disability, instead of going through relapses up and down, it will go through a slowly progressive phase. This phase has been termed secondary progressive. If the patient come to our attention only from the progressive phase, we term those primary progressive MS. The genetics, the pathology, and the imaging between primary and secondary progressive phases are all the same. What's interesting lately was the preclinical phase. I can use this. So this preclinical phase has gained more interest as many people started ordering MRI for several things, mostly migraine headaches. We started picking up the MRI events that are most of the time occurring during the relapsing remitting stage. Some of them do occur before the clinical isolated syndrome develops, and the name that was referred to was radiologically isolated syndrome. These patients have imaging classical for multiple sclerosis, yet they have no symptoms to target with treatment. Inflammation generally occurring throughout the disease, most prominent during the relapsing remitting phase, and continues during the progressive phase, but to a lesser extent. And the other side of the coin in MS is the axonal loss, the neurodegenerative component. And we found lately with data from the Mayo Clinic that the degeneration can happen in some cases, even some people think it can precede the demyelinating lesions, which can give a hint to which came first, the neurodegeneration or the neuroinflammation. It continues throughout the disease, and at a certain point of a threshold, the disease is not anymore with a prominent inflammatory component. It becomes mostly neurodegenerative in nature. Correspondingly, there is decrease in brain volume at a faster rate than average population. So how do we diagnose MS? The general rule still holds true, which is it's a clinical diagnosis confirmed with magnetic resonance imaging. There is no much role anymore for CSF and for evoked potential. However, there are more than 100 disorders that can mimic MS, clinically and or radiologically. So we should look carefully for those red flags. However, when you want to diagnose MS or you're dealing with a patient who's most likely having MS, avoid what's known as the shotgun approach, where you just send 100 tests just for all rheumatological causes, infectious, and everything under the sun. Once a patient is labeled with MS and you start treatment, then it becomes a problem to later on de-diagnose them. Tell them that you don't have MS, you developed some extra signs that pointing toward different diagnosis. So instead, you can use the term work and diagnosis until you're 100% sure about it. In any event, if you're not sure, if you're in doubt, avoid making a diagnosis. Just follow the patient with repeating imaging and see if they develop a full clinical picture of MS. So the classical presentation comes in two forms, either clinical relapses or some chronic symptoms. The relapses are generally optic neuritis, which is the commonest, followed by transverse myelitis, brainstem syndrome, cerebellar syndrome. These are classic relapses in multiple sclerosis. There are some symptoms that are chronic and they are almost always there in all patients, especially later in the disease. However, many times you have to ask the patient to get the history about these symptoms. Fatigue is very common, almost everybody. Many times fatigue precedes all other symptoms. Paresthesia, that's not dermatomal, not following a certain dermatome, and you cannot localize it. They'll just tell you I have numbness on and off on the tip of my fingers. Many times the primary care would tell them just let's get an MRI and get it done with, and then they discover the patient have multiple sclerosis. Depression and cognitive dysfunction. It's believed that these are related more to the axonal loss more than the neuroinflammatory component. And most of the time you have to ask the patient and do those battery of tests to pick them up. So next is the red flags. So what do we look for? We can divide them into red flags in terms of history and the clinical data, and red flags with the imaging. So any patient who have history away from the classical MS, which is a patient between the 20 and 40, coming with relapsing, remitting disease process, is kind of a red flag already. So if you see there is only one lesion in the brain, there is progression from onset, it's occurring in the extremes of age. MS can occur from, I think the youngest reported was 5 years old, and the oldest is 90-something years old. But most likely you see them between the 20 and 40. Prominent family history. There is family history with MS, but it's not that strong family history. Gray matter symptoms. Usually the relapses should be localized to the white matter tracts in the central nervous system. And any other symptoms outside the central nervous system is probably a red flag. Then the imaging. There is the classical MRI picture of multiple sclerosis, which I'm going to show you next. Anything away from that, either the extreme of it being totally normal MRI or MRI with big lesions, extensive lesions, make you a bit suspicious. If you do a lumbar puncture and it shows a negative oligoclonal band, or the opposite, severe inflammatory reaction, that might give you a hint that you're not dealing with MS. So we use as you all know, the McDonald's criteria, the updated one from 2010, and it needs two things. One is dissemination in space, and second, dissemination in time. For dissemination in space, we need one lesion in at least 2 of the 4 classical MS locations of the brain. One of them is the juxtacortical, where the lesion is touching the cortex. One is periventricular, the famous Dowson finger, where they're touching the ventricle. And then the infratentorial, that are in the brainstem and the cerebellum, and lastly in the spinal cord. If you have any of these two lesions at any time, then you fulfill the criteria for dissemination in space. Next one is dissemination in time. This is more interesting. As a patient who's come in with only one clinical event and with only one MRI, you can find one enhancing lesion and one cut, and other non-enhancing lesions. This by itself satisfies the criteria for dissemination in time. Usually the contrast enhancing lesions are more recent, usually up to a month, rarely 2 months, that they continue to enhance. Otherwise, you know that they're older lesions. If that wasn't the case, you have only non-enhancing lesions, you just follow the patient up with a second MRI, classically in 3 to 6 months, and you can start seeing new lesions that were not there before. So that will satisfy the second half of the criteria, which is dissemination in time. At this point, you made the diagnosis of MS. And then treatment is very interesting in MS, especially over the past few years, as many medication came to the market. So we divide the management into treatment of acute relapse, disease-modifying therapy, management of MS symptoms, and some other measures. I'll be focusing today on the first two. So back to our natural history slide. We have the window to treat those acute relapses. So basically, the relapse is a new symptom attributed to the white matter of the central nervous system in the absence of fever or infection. Once you satisfy that, then you're dealing most likely with a relapse, and then you can treat them. The classical treatment is IV methylprednisolone, 1 gram for 3 to 5 days. Some people like to use PO taper steroid, and some people prefer not to. Some studies have shown that the PO and the IV medication are equivalent, and you can use either one. For any contraindication to corticosteroids, you can use plasma exchange. IVIG can be used too. The benefit that we're sure about is that it will shorten the duration of the relapse. However, if you follow the patients after 6 months, and mostly after a year, whether you give them steroids or you don't give them steroids, most of the time they reach the same point. There is some earlier evidence that it might impact long-term disability if it's used earlier, but it seems more off if you use it more frequently during the course of disease. So in a way, becoming a disease-modifying therapy. There are instances when we don't use steroids. One of them when the relapse is very mild. It's not impacting the patient function. The patient coming to you in clinic and saying, I just had some numbness or some double vision, it comes and goes, but it's not really bothering me. So at that point, it's not worth the risk of giving them steroids. The other important thing is what's known as pseudo-relapse. That's when it's not a true relapse. Patient will have ideally reappearance of old symptoms or worsening of old symptoms, usually lasting hours to days, unlike the true relapse which lasts weeks and months. Usually they come about with infection, fever, hot weather, exercise, and usually once you treat the primary cause for it, they go back to baseline. And in these pseudo-relapses, steroids have no obvious treatment, no obvious benefit. So this is the most interesting part in the MS research field right now, is disease-modifying therapy, as we're getting a new treatment every year almost now. So we have 13 approved FDA-approved medication. They are between injectables, which are the first generation of medication, oral medication. We have 3 medication: fingolimod, teriflunomide, and dimethyl fumarate. And lastly, the infusion medication. The last medication that came to the market was alemtuzumab a year and a half ago, and now we have it available in Kuwait. This medication, you give it once a year for over 2 years, and then you just watch the patient with MRI and just follow-up investigation, basically. Tysabri is one of the interesting medications the patient like a lot because you only take it once every 28 days, once a month, basically. And there is some evidence that you can take it once every 2 months, but we still don't have firm data to start applying it to our patients. So These medication would help with three things. One, reduce the relapse rate. So instead of the usual relapse that happens once every 2 years, when you put them on a good medication, the relapses would ideally be delayed 5 years or every 10 years, and that's when we call it a medication failure most of the time, and we would switch to another medicine. The second thing, it will reduce the MRI activity. They will have less accumulating lesions, less lesions that are getting larger in size, less lesions that are enhancing with gadolinium. And lastly, some of them have impact on disability, but this is still an open area of research for longer-term trials and see if they truly impact disability. As you know, clinical trials goes for 2 to 3 years maximum, not enough to really judge disability accumulation. This is another way to look at this medication. So we can divide them into first-line medication, which are basically the injectables, the interferons, and the glatiramer acetate. 2 of the oral medication. These medications are fine to be first-line, as they have a tolerable side effect profile, and they have a decent efficacy. A second line would classically be a stronger medication. They'll have more side effects, but stronger efficacy. So it's always a balance. And lastly, if we need to, there are some off-label medication. Examples would be rituximab. Hematopoietic stem cell transplantation has been getting a lot of attention. We know it works very well. However, we don't know where to fit it in the algorithm of when to choose which drug, as it carries much more toxicity compared to the benefit that it offers compared to the other ones. Okay, so bear with me for a minute here. So let's imagine there's a line of people. They keep moving, and eventually they get to the end of the cliff, and they will jump off. When they jump off, they reach the degenerative phase of MS, where medication will not help them anymore. So this is basically their window. So far, so good? Okay. Next would be some patients have infrequent, mild relapses, usually recover fully. And when you look at their MRI, they will have very low T2 lesion load. We call these low-risk patients. And ideally, we're talking about these patients here, the group that has enough time before reaching the end of the cliff here. So these patients, we can give them first-line medication, and if it fails and we need to switch, we have time to switch even between the first-line medication, from the injectable to the oral medication. They have some time. To the contrary, this group of patients, they tend to have the severe relapses, early disability, and usually some residual deficit from each relapse they would have. Usually their MRIs will have a lot of 2-2 lesions. So they don't have a lot of window available for them before the medication won't help them anymore. So for these patients, we call them the higher risk patients, and we can start with second-line therapy immediately. It's only a few years that we can slow the disease progress. Sometimes after given a first-line treatment, the patient will develop more activity, new lesions on MRI, a new breakthrough relapse, and in that case, we have one of 3 options basically. One option would be to switch between the different first-line medication if the patient is still in the early stage and still mild disease. So we have a chance to switch between those medications. If we think that he moved from this group down to this group with a severe relapse, didn't recover from it, didn't respond well to steroids, so it's time to switch him to a second-line medication. If they develop more disease activity on the second line, then we can go to some offline medications or between those second-line medication also. Some important role for the non-neurologist in MS. As you can imagine, most of the patients, if not all, will be noticed by a non-neurologist in the beginning, either a primary care, the internist, a family doctor, whomever is treating them for other autoimmune diseases. So they will be the first line of considering MS as a diagnosis. So just have high index of suspicion. If you have somebody in the classic age distribution having relapsing central nervous system symptoms lasting usually days and weeks or maybe months. So consider MS in your differential diagnosis. And remember that when you order brain MRI for MS, always order it with and without contrast or gadolinium. And you will see this a lot. MRI report for somebody with migraine headache, it will come back reading demyelinating disease or even mentioning multiple sclerosis. This does not equal a diagnosis of MS. So don't tell the patient you do have MS just based on the report. Have an MS person look at them better in the beginning. Not every relapse requires corticosteroid treatment, so just be aware of the pseudo-relapses. So look for the fever, look for infection sign, especially in patients with advanced disease, especially with patients with already existing disability. And the disease-modifying therapy usually are more effective if started early in the disease. Once you pass the early window, their benefit kind of wane down a little bit. That's all. Thank you very much for your attention.
Thank you very much, Dr. Tariq. Very interesting presentation. You can join the panel. So, one of our speakers is disappeared. تعال حياك. You're going to have the tough questions. So, anybody has any question? Welcome to ask. I want to open, I have to say, I'm a cardiologist and I learned a lot today. There's hepatitis C has been eradicated, MS treatments, venous thromboembolism, and diabetes. Probably learned less about the diabetes because we know so much about it. But I want to start by asking Professor Linsing, just out of interest, who treats DVT in the Netherlands? Is it a vascular person, an internist, cardiologist, specialty-wise? Who handles DVT treatment?
Your DVT patients are usually treated by the internist.
Okay.
However, what we see increasingly happening now is that patients are not referred to the hospital anymore, but are being dealt with by the family physician in collaboration with a diagnostic facility. So many patients do not reach the hospital anymore, in contrast to not so long ago, where almost all patients were even admitted in the hospital.
All right.
For pulmonary embolism patient, however, it is still the internist, the lung physician or cardiologist that is playing a crucial role, and most patients are seen in the hospital.
I don't think that's the case in Kuwait, Dr.
It's the
Amori.
case in Kuwait, yeah. DVT and PE, they are being admitted under internal medicine.
Yes, yes, but not treated by GP
No,
or,
so far
family
the GPs, they
physicians.
refer the cases for us to the hospital, yeah.
And how do you see, I'll ask them that, how do you see the introduction of an antidote? You mentioned an antidote about bleeding. I mean, the bleeding data were so favorable compared to warfarin. Do you really need an antidote? Is it going to make things worse?
Well, I think that doctors who want an antidote better need a psychologist. And that is because there is so much noise about an antidote and nobody knows anymore what it is really about. A patient that is having a bleed is not expected to stop bleeding when an antidote is administered. An antidote is reducing or is neutralizing the anticoagulant activity. What we need is thrombin activation. We need plasma, we need factors, activated coagulation factors to stop the bleed. That is exactly what we also do with warfarin for 40 years. We give vitamin K. Vitamin K is stopping the anticoagulant activity. By the way, it takes hours for a very long time. So the patient who is bleeding in the emergency room, the bleeding is really not stopping when you put in vitamin K. That is the antidote. But it's a long-acting anticoagulant, so you need to give an antidote. But what we do is fresh frozen plasma, transfusion, and coagulation factors. That is how we control bleeding already for 40 years. That is how we're still doing it, and the situation has not changed. And always remember that the new oral anticoagulants have a very short half-life. It's not a long-acting drug anymore like warfarin, that you have an INR elevation for days, but at the end of the day, all rivaroxaban and apixaban and doxaban is gone.
Great. There's a question there.
Thank you. I'd like to thank the panel. It was both enjoyable and informative. I have a couple of questions, please. One is the use, could you comment about the use of You didn't comment in your talk about the use of the anticoagulant drug. You talked about in HITS positive patients initially in the first 3 weeks where they need anything to prevent a thromboembolic episode. And my other question is for the neurologist, and it's the use of fish oil in MS. You didn't talk about that as an immunomodulator agent. Is there any role for that? So what is for the hematologist and what is for the neurologist?
So we'll start with Tariq. It's, what is it, omega-3
Yes, Omicor, the use of Omicor in MS.
for MS? يشغل. It's what?
Okay. Beside the medication that we talked about today, which have multi-million-dollar powerhouse pharmaceutical industry behind, every other thing, it will be very hard to commit a high-quality clinical trial to give us a solid result to base our conclusions on. Having said that, with fish oil and omega-3, they've been shown with several studies, especially mouse models, that they do affect the brain function, they do affect the remyelination in a couple of studies, I think from Australia, if I'm not mistaken, but we have no clinical trials that showed benefit on MS patients. Having said that, almost always my patient asks me about what do they do in terms of diet, in terms of all the complementary medication. And I'm very open, vitamin D, fish oil, multivitamins. As long as you're not going to a toxic levels, you're not taking too much of them, it will not hurt. But I cannot promise them that it will do impact their disease status, unless I have solid clinical evidence in my hand.
Sorry, Doctor, what was the question on the anticoagulation? HITS?
First 3 months.
Well, we did not perform a large study so far to demonstrate that, but we have many case reports now, and the evidence is really accumulating as we expect that there is no interaction between rivaroxaban and HIT antibodies. And I am using it. I did it now in 4 patients with HIT, and that went perfectly fine. Also in the literature, I think we have something like 25 cases already documented well, with a very, very effective outcome.
I have a question for Professor Fouad Al-Ali regarding what shall we do as internists in our clinic with hepatitis C positive serology and the initial steps that should be done by us and when to refer to the hepatologist.
Positive antibody against hepatitis C doesn't necessarily mean that the person is infected. In low-risk populations, up to 25% are not infected actually. So it has to be confirmed by PCR. If the PCR is positive, they have to be referred for the gastroenterologist or the hepatologist. I would do it if somebody's anti-ACV positive, I would do the PCR twice, 3 months apart. If they are negative twice, then I would not consider that person infected.
And Professor Fouad, did I hear you saying genotyping? I was wondering, like, do you do genotyping to decide which medication to use?
Absolutely. So genotype is a major determinant of response. And as I showed in some slides, some of these new agents may not be effective against certain genotypes. So we have to do the genotyping before deciding upon what is the optimal
This is
choice.
easily available?
Yeah, it's routinely available, yes. Routinely available.
I have a last comment, and we'll probably close the session for Waleed. Yani, you know, Dr. Waleed, we always meet and talk about diabetes and how we have a huge problem, but really, when you think of the epidemic, if you call it, how can you control it, or can we ever control it, or what needs to be done? Is it governments? Is it Kuwait Medical Association? We're having a KMA sponsored conference. Is it what? Is it diabetics, diabetologists? How does it work?
I mean,
They
ju-
got rid of hepatitis C virus. Can we get rid of diabetes?
I mean, diabetes is a more complex disease than hepatitis, and it's very difficult to control because there are lots of partners in the equation. You have people, government, providers, lots of things. But I think because, as I showed you in Kuwait, the rate of increase in this and the prevalence in the Gulf is not only in Kuwait. They all have this sharing the same thing: physical inactivity, increased food intake, obesity early, and that's one of the three things. On top of that, we know that there are lots of genetic backgrounds going on related to diabetes, and diabetes, it's a polygenic, so there's no one single gene. So it's also very difficult to cure it from this part. So if you want the cure of diabetes, or let's say if we want to reduce this increase in the prevalence, I think things should happen in the community more than in the hospitals.
What about
Yeah, the way we live is wrong. Our areas is made wrong. The living areas is wrong. If you look at the houses that the government made for us, or the way they structure the areas that we live in, it's all non-workable areas. There is no pedestrians at all in our areas. All over the world, if you have a home, there is something like 10 or 50 meters, and there is a walk. You can go out and walk. You go to everywhere. There's no walking areas. Fast food chains are all over the place. They do delivery. They do advertisement around schools. Most of the developed world now, they have no delivery. They don't allow fast food around half-kilometer circle around schools, for example. All of these things have to change. The mentality of the government that you can buy a medicine for diabetes. We have all medicines for diabetes. All medicines
I was
available.
gonna say we have lots of medicines, and in the
SGLT2s,
polyclinic,
even the SGLT2 inhibitor, the latest diabetes class, 2 of the drug now approved in the Ministry of Health, but that will not solve the issue. It's a big thing, more than just medication.
what about stem cell transplantation or pancreatic
Yeah.
transplantation? Is it
Yeah, stem cell,
possible?
yes, stem cell and pancreatic islet cell transplants are two things. Because of the time issues, I did not put them in my slides. Now, islet cell transplant is something more geared toward type 1 diabetes. So this is not as an option for the population. Stem cell transplant still it's not approved yet as a treatment to be used commercially. Although there are lots of Kuwaitis now going to India, Ukraine, Kiev, and to Germany, and if somebody have more money, they go to Switzerland too. They do islet cell transplant, stem cell transplant. Some of them are autologous from the bone marrow, some of them are from placental, and some of them are fetal. Nobody knows what's the process there. I tried to talk to people in India and Ukraine in particular, and these are all like commercially based groups. Nobody knows where they get their cells. Nobody knows, how they treat the cells when they inject the cells back in the body. Nobody knows what's the long-term effect. How much of these cells will turn up to be cancer? Nobody knows. Mostly they get the effect within the first 6 months, and then as any stem cell, but it's still too early to
yeah, I've had a
decide.
couple of patients coming from Ukraine, and it was a joke.
Yeah,
So,
yeah.
listen, thank you very much. Thanks on behalf of my co-chair and behalf of KMA. I'd like to thank the audience. MashaAllah, really nice audience at this time of the day. Thank the speakers for their great presentations, and hope to see you sometime. Thank you very much.
تسلم دكتور.
everyone. Thanks again for coming. I'm Dr. Abdullah Al-Mutairi. I'm one of the consultants in the intensive and pulmonary care. I would like to introduce my co-chair, Dr. Adela Al-Matrouk. She's one of the our consultant in the intensive care unit in Farwaniya Hospital. Welcome, Dr. Adela. And as a ritual, always in any conferences, we keep the best to the last. Okay, so we're gonna deal with the best part of medicine in general. So in this part, or in this last part of the conference, we will be talking about issues or areas in the updates in the intensive care medicine. And it gives me a great pleasure to introduce Dr. Kashani, Kinosh Kashani, who is one of the well-known figure in the critical care medicine and in the nephrology also field. He's an assistant professor of medicine and the medical education, and he's currently the consultant in the division of the nephrology and hypertension and the division of pulmonary and critical care medicine in Mayo Clinic, Rochester. And he will talk, actually he will have 3 excellent talks back to back. We will start with the updates in the management of sepsis. Then afterwards, we'll talk about the updates also in ARDS management. And at the end, or his third talk, will be about management of fluid and volume replacement. What we're gonna do, we're gonna take the whole 3 talks all together, and we will leave the discussion at the end. So without any further ado, Dr. Kashani, welcome.
Thank you very much for kind introduction. I have to truly thank the organizing committee for invitation. This has been great. It's my 4th time in Kuwait, and each time I find new friends, and it's been really fantastic. You guys have heart as big as gold. So thank you very much for invitation. So this is where I work. This complex is outpatient. This is Methodist Hospital. This is St. Mary's Hospital. We have about 2,000 beds, about 250 ICU beds. And this is Henry Plummer building. It was built in 1950. Henry Plummer was our first internal medicine physician, was hired by Mayo Brothers. And if you remember Henry Plummer-Vinson syndrome, he's the Plummer part of Henry Plummer-Vinson syndrome who made this. He was a revolutionary and very good thinker. So I invite you to come to see us at Mayo Clinic. It's a town that is built around the hospital. It's unlike other hospitals that are built in the cities. The city is built around Mayo Clinic. But when you plan to come, make sure you don't come over winter. We have very, very difficult winters, you can see. Now let's start. These 3 topics, we spent 2 years to teach our fellows these 3 topics. I'm trying to concentrate that in about 1 hour. So these are the outlines of acute respiratory distress syndrome. We know that ARDS, or so-called lung attack, is due to diffuse injury to blood capillary barrier that results significant leakage of fluid into the alveoli and results inflammation. And as a result of that, we have significant decline in oxygenation, which is indicated by the ratio of partial pressure of oxygen to fraction of inspiratory oxygen. If that ratio goes below 300, usually patients make criteria for ARDS. They usually should have bilateral infiltrates in a chest X-ray, as well as you can see in this particular patient, and we need to make sure that they do not have heart failure or left atrial hypertension to result all that infiltrations in the lung. There is a European definition, Berlin definition, which is a consensus definition for ARDS and includes several different pieces. First, it has to happen within 1 week of insult. So if you have a patient who had pneumonia last year and has bilateral infiltration and no other insult, it's hard to call it ARDS. Chest image should have bilateral opacities and should be due to, we should rule out lobar lung collapse or effusions or nodules. We need to make sure that origin of edema is due to inflammatory state, and we have to rule out cardiac failure and volume overload. And we will talk about volume overload later, but there should be some objective measurement of that. So our fellows, like a lot of our intensivists in Kuwait, we monitor patients using echocardiogram and lung ultrasonography to achieve that. Oxygenation is an important part of definition. So all of these patients need to be on some sort of positive pressure. If they are on positive pressure, then we judge the severity of ARDS based on PF ratio. So if it is less than 300 but more than 200, then it is mild. When it is between 100 to 200, it is moderate. And less than 100, it is severe ARDS. In United States, it is not very common disease. It is about 200,000 patients per year, results about 75,000 deaths per year, and 3.5 million hospital days. So as far as the number of patients are not very significantly high in comparison with number of ICU admissions. However, the burden, financial burden of these diseases is significantly high. 40% of these patients die if they have particularly moderate to severe acute respiratory distress syndrome. And also it affects long-term quality of life and certainly increases cost. This is a study that our group did in Olmsted County, which is the county that Mayo Clinic is located. And we showed between 2001 to 2008, we decreased incidence of acute lung injury constantly. And we looked into different processes we implemented through this time period. And there are several different things that we did that we believe that they have affected the incidence of ARDS, including transfusion. We have placed a significant restrictive transfusion policies. Mechanical ventilation, we will talk about the strategies of lung protective mechanical ventilation. We started resuscitating sepsis a lot earlier. We take care of patient with pneumonia as an inpatient. We have 24/7 intensivists in-house. We implemented rapid response team, and we have enhanced the quality of electronic records, so we electronically know whoever reaches that criteria for acute respiratory distress syndrome. So all of these together potentially have impacted the incidence of acute lung injury in our institution. It is not one mechanism that results ARDS. There are several different pieces that can affect this barrier between gas and blood. One could be mechanical, like when we use not healthy respiratory mechanical ventilator strategy, or could be chemical by acid aspiration, or could be biological. It could be direct infection in the lung, pneumonia with viral pneumonia or bacterial pneumonia, or could be indirect by inflammatory states in other body parts. They all result membrane injury. When a membrane injury happens, it results more inflammation. And this is a vicious cycle that patients go through. Unless we break that cycle, patients continue to progress toward higher permeability, capillary permeability, and pulmonary edema, and that results lower quality of life and increased cost. It is usually a two-hit lesion. So at the very beginning, first hit, patients come with a baggage of risk factors. For example, pneumonia, toxic inhalation, pancreatitis, sepsis, shock, higher age. These are all risk factors for acute lung injury. If we modify these risk factors and try to avoid further progression, like providing appropriate PEEP, moderate oxidative stress, and inflammation and coagulation, we can potentially avoid these patients to move toward ARDS. However, if patients receive high tidal volume, they receive inappropriate transfusion, they have delayed resuscitation or inappropriate antibiotics or aspiration, and we use very high fraction of inspiratory oxygen, we can basically push patients to have florid acute respiratory distress syndrome. These are risk factors for acute respiratory distress syndrome, including chronic alcohol use. I just saw the incidence of diabetes. One good news is that diabetic patients do not develop ARDS. So diabetes is protective against ARDS. Maybe this is one shred of light that we have. Smoking is a risk factor. Hypoalbuminemia, acidosis, obesity, and silent aspiration are all primary hits. Using bad mechanical ventilation strategy, high fractional inspiration of oxygen, using inappropriate transfusion and volume overloading these patients certainly pushes them towards more severe ARDS. Mortality is very significant. About 1 out of 5 dies in ICU, about 1 out of 4 dies in a hospital, and 40% of these patients die in 6 months. So it is a very impactful syndrome that happens in ICU. Indeed, in a follow-up, 5-year follow-up of this patient, as you can see, these are all patients who had the first hits risk factors. So these are all high-risk patients for ARDS. Some of them developed ARDS, some of them didn't. Those who developed ARDS, most of them died within the first month or 2. And the rest of the curve, follow-up 5-year curve, as you can see, this become parallel. So the separation of these two curves happens within the first month or 2. And this is one of the criteria of ARDS, is that if they pass the critical point and start recovering, then their outcome is probably not too bad. We also have followed this patient for a very long time. It seems that even though if they recover their lung function, they still have profound effects of ARDS in their life. So first of all, they become really weak. They lose their memory. And because of loss of memory, they develop post-traumatic stress disorder signs and symptoms. Some of them look withdrawn, which could be due to depression or delirious state. It is usually under-recognized, and they have families, they are affected by all these changes in memories and PTSD. One of the things that we found that is effective in avoiding all these is that if a nurse or family member take a journal and write down what is happening during the time that they are intubated and a mechanical ventilator, the risk of memory loss and cognitive impairment is less. The reason is that when patients are sedated on mechanical ventilator, they wake up, they have some snapshots of what is happening during that time, and they cannot connect these dots together. So they are completely lost. They become more and more confused. If you can have a journal to say what happened and who came to the room and what procedure you underwent, then they can connect all these dots, and cognitive impairment is significantly less. Now, how do we treat it? First important thing is to know how to manage mechanical ventilation in these patients. So non-invasive ventilator could be potentially used, but we know if non-invasive ventilator fails, chance of mortality goes up. So you have to try to identify patients that have higher risk of failure of non-invasive ventilator and avoid the long trials. So trials should not go beyond an hour or 2. If patients do not do well on non-invasive ventilator, plan to intubate these patients. Believe it or not, intubation is not that dangerous. Now, who has higher risk for failure? Those who are in shock, those who have metabolic acidosis, those who are sicker, that have higher severity of illness scores, and those who have lower PF ratio. Now, what do we do with mechanical ventilation? There are 2 different types of damage by mechanical ventilator we try to avoid. One is atelectasis trauma, which basically when you don't use appropriate positive expiratory pressure, what happens is that alveoli collapse and open, and all that results significant damage to the alveoli. To avoid that, we need to use appropriate PEEP. Therefore,